So let's look at the pelvis and the anatomy around it. The pelvis is essentially that supports and protects the viscera. So it acts as a functional structure, and it is said to be a keystone to support the lumbar spine. And one of the things that it does is it serves for muscle and ligament attachment, and it acts as the dynamic link between the spine and the lower limbs. So when you think about when we're walking, when we take a step forward, let's say with our right foot, we're absorbing ground reaction force, and that load has got to be transferred through that lower leg, eventually through the pelvis, and across the pelvis into the lower back, and then eventually into the opposite arm. So the pelvis acts to reduce and absorb torsional stresses when we're walking, and it does so by allowing some gliding and sliding type movements, particularly through the sacroiliac joint and through the symphysis pubis joint. So one of the things we'll be looking at later is just how the sacroiliac joint does move, because it used to be thought that it never did move, but it actually does move. Not a whole lot when you evaluate this clinically, but it certainly does move, and it's something that clinically can be evaluated. So think of that as a functional structure in absorbing forces and reducing stress. Now when we look at the sacrum, otherwise known as the sacred bone, if you look at this picture on the webinar here, what you'll notice is just some depressions that serve as attachment sites for some of the ligament structures, in particular the dorsal interosseous ligament. The median sacral crest is another structure that's easily palpable clinically. The unfused spinous process of S4 and S5, otherwise known as the sacral hiatus, can also be palpated clinically. And then along with that, on either side, the sacral cornua. The inferior lateral angle is a popular structure that's palpated clinically when we're looking at positional findings with respect to the pelvis and the sacrum. The intermediate sacral crest, and then you have the foramen. And the dorsal sacral foramen is where we get some of the nerve structures that exit through. All right, and then we have essentially the lateral sacral crest. So the lateral sacral crest is basically fusion of the transverse processes of S1 through S3-4, and the median sacral crest is fusion of the spinous processes of S1 through 3. So this sacrum, keep in mind, is generally a triangular shape, but it does vary quite a bit from person to person. And so, for the most part, we think of it as being a triangle, but keep in mind that there's variance from one person to the next. All right, if we look at the sacrum from a top-down view, transverse view, then we can notice that the spinal canal is trifoil, sort of a triangular shaped, and so this is where a lot of the spinal nerve basically will exit into or go into. One other thing that I would like you to be aware of is if you look at the superior articulating process of S1 and sort of the shape that it shows it to be. Now sometimes you can see this as being a sort of a flatter shape of the facet surface, but sometimes it's a curved shape of the facet surface. Now clinically, how's that relevant? Basically, when you go to evaluate the movement at L5-S1, you have to appreciate that on one side you may have more of a coronally biased facet joint plane, and on the other side you may have more of a sagittally biased facet joint plane. So that just is sort of playing around with the L5-S1 motion segment when you are evaluating it clinically. So something to be aware there. And then you have the sacroala as well. So let's look at now the sacrum from a sagittal view. And really what I want to point out here is that the sacral, this SI joint surface has sort of two divisions to it, if you will. If you notice that black line in the middle of that SI joint articular surface, we can sort of break it up into what we call a short arm or a long arm. So if you would imagine the L shape sort of laying on its back in a sense with the head dipped down, if that makes any sense to you. You can see that the longer part of the L would be considered the long arm, and it generally faces in an anterior to posterior direction. So movement in this part of the joint generally moves in an anterior to posterior plane. This is at the level of around S2, S3. Movement in what we call the short arm, or the shorter part of the L shape, is at the level of S1, but it's in the craniocaudal plane. So movement is more in the superior to inferior direction. So clinically, there has been some speculation as to whether you can evaluate these two movements separately, in a craniocaudal versus an anterior-posterior. My clinical experience and thought on this is essentially that they move together. So you evaluate the movement of the innominate on the sacrum, and generally you're evaluating movement in both the anterior-posterior and the craniocaudal plane. Some therapists will be able to tease out some of these movements as far as craniocaudal and anterior-posterior, and others don't feel like they can feel it. So it really becomes a perceptive component. In any case, what I'd like to sort of emphasize is that there is movement that occurs, and it generally occurs in this movement pattern, craniocaudal to anterior-posterior, and the movement happens together. And that's going to drive some of the biomechanical movement when we look at evaluating innominate motion on the sacrum or sacral motion on the innominate. All right, looking at the innominate, it's primarily made up of the pubis, forms the inferior medial aspect, and the ischium, which forms the inferior lateral aspect or lateral third of the innominate. The ischial tuberosity we know to be a site of strong muscle and ligament attachment. So generally you have a lot of muscle and ligament attachments between the ilium, the ischium, and the pubis. Three bones essentially fused into one that comprise the acetabulum. The ilium is fan-like. The sacroiliac joint surface, or where the sacroiliac joint would be articulating, you can again see that purple line that shows sort of like an L shape. That's the articular surface of the SI joint. And if you look at it, you can see that in a real model or real bones, you would notice that there's ridges and grooves. And these ridges and grooves within the SI joint surface actually facilitate some stability, some friction, so that you don't have too much superior to inferior movement. Now, looking at the sacroiliac joint itself, it is a synovial joint, and the sacral surface is said to be hyaline in nature with its cartilage, whereas the ilium has fibrocartilage. It does have a capsule, and it's got a couple of layers of a capsule, an outer and an inner an outer fibrous layer and an inner synovial layer. And the capsule is said to blend with the deep interosseous ligaments, the posterior ligament structures, and the periosteum inferiorly. So bottom line is that you get some blending in of the capsule with the ligament structures, and so you get support of the capsule by the ligament and the fascia that connects to those ligaments as well. So there's a lot of support for this SI joint. What you're seeing here is a picture of a sacroiliac joint of a 3-year-old male, actually, and it just basically shows how one side, the sort of blue dull side, is actually fibrocartilage, whereas the sort of whiter, shinier side is actually hyaline cartilage. All right, so some of the ligament structures to be concerned about when you're evaluating this region is the iliolumbar ligament, which has various fibers, which we'll discuss. It's got a superior fiber and some vertical fibers and others that I'll talk about a little bit later. The ventral SI ligament, sacroiliac joint ligament, the sacrotuberous ligament, the inguinal ligament, which really just runs from one part of the innominate to another part of the innominate, the sacrospinous ligament, and the superior pubic ligament. Most of these ligaments obviously are supporting joints and limiting motion. The inguinal ligament doesn't really support a joint or limit motion in any way, but rather serves mostly as attachment site for muscle and fascia. So the SI ligaments, let's look at the ventral SI ligaments. They're fairly weak, and of the sacroiliac joints ligaments, they're the weakest. Thickening of the anterior and inferior parts of the joint capsule is really what they are. So it's just essentially a thickening of the actual capsule, and that's what we consider to be the ventral SI ligaments. Now, one of the strongest ligaments in the sacroiliac joint is the interosseous ligament. And this picture here basically shows a transverse section of the sacroiliac joint bilaterally. And what it shows is that the interosseous ligament within the SI joint really fills in much of the gap within the SI joint. So it's very thick and very strong, and the fibers are multidirectional, completely filling in the space, and you're going to have deep and superficial layers. Now, clinically, we can't really palpate any of the deep or superficial layers, but what we want to know is that it serves to limit the motion of nutation, of sacral nutation. So when you tighten this ligament up is with movements such as sacral nutation. So we'll talk a bit about sacral nutation and what motion that is a little bit later, but essentially it means when the sacrum will sort of flex or dip forward at not at the apex but rather at the base. All right. So when the sacral base tends to dip forward, or sometimes people refer this as being sacral flexion, that we term to be sacral nutation. And this ligament will tighten up with that motion. So clinically, this is significant to know because that is a position of stability, and we want to remain in a position of stability through our SI joints. Now, the long dorsal ligament. The long dorsal ligament is a clinically relevant ligament. Just go through some of the anatomy around it first. It essentially attaches to the deep thoracodorsal fascia, or the thoracolumbar fascia. The erector spinae aponeurosis also blends in with this ligament. The sacral multifidus and the sacrotuberous ligament also have fascial connections to this ligament. So essentially, this ligament acts as a functional link between the legs, the spine, and the upper quadrant. Essentially, through that fascial connection, it has blending in with, as I said, the sacrotuberous ligament. The sacrotuberous ligament essentially joins into the tuberosity, and what connects to the tuberosity is the hamstring muscle group. Now, through fascial connections, you've got a connection here with the long dorsal ligament. Because the long dorsal ligament also blends in with the thoracodorsal fascia, then you've got the latissimus dorsi muscle that's enveloped within this fascia, and now you have a functional link to the upper extremity, and that is generally the opposite upper extremity that it's linked to. So contraction of the latissimus dorsi and glute max muscles will actually reduce tension within this ligament. Contraction of the erector spinae and loading of the sacrotuberous ligament will increase tension of this ligament. So one of the clinically relevant components with this ligament is that some research that's been done by Vleeming et al., and it dates back to the late 90s, is that they found this to be a source of pain in 88% of people with unilateral pelvic pain. So people who came with sort of unilateral pelvic pain, typically posterior SI joint pain, would notice that this ligament was a sensitive structure. And in 88% of those people, this is what the ligament was. This is the ligament that was sensitive. One of the things that this ligament does is it tightens with sacral counternutation. So sacral counternutation, where the sacral base moves more towards a posterior direction or more towards extension, let's say, of the sacrum, is a position of, let's say, instability, okay, or unlocking of the SI joint. And so when you have this position that's maintained, the long dorsal ligament gets stretched, and it's very pain sensitive, and that's where people with SI joint dysfunction may end up having reports of pain, and it's due to this ligament for the most part. Okay, moving on to the sacrotuberous ligament. The sacrotuberous ligament attaches to the gluteus maximus muscle, the biceps femoris, and the deep fibers of multifidus. It has 3 bands, a lateral, a medial, and a superior band, and they span into various directions into the ischial tuberosity. From there to the PSIS, spans the piriformis. The medial branch basically goes from the lower sacrum and the coccyx and into the ischial tuberosity, of course, and then the superior component of this ligament connects the coccyx and the PSIS together. It is pierced by S2, S3 cutaneous nerve, so any excessive tension in this ligament potentially can cause some neuralgia or cutaneous nerve sensitivity in the S2, S3 region. It tightens with sacronutation. Okay, so the other ligament that tightens with sacronutation is the sacrospinous ligament. So here's a diagram of the sacrospinous ligament. You can see that it attaches medially to the sacrum and coccyx and laterally to the ischial spine. It blends with the sacroiliac joint. It's thin and triangular, and it's said to be responsible sometimes for coccydynia. This ligament is said to be a degenerated part of the coccygeus muscle. So back to the iliolumbar ligament. The iliolumbar ligament connects L4, L5 transverse process to the ilium. So L4 and L5 transverse process is connected to the ilium via the iliolumbar ligament. So what's its function? Well, clinically, it provides stability in a coronal plane and in the sagittal plane of particularly the lumbosacral junction. It's highly variable in number and in form, and it's said to be muscle up to the 3rd decade of life, and particularly the posterior band is said to be part of the iliocostalis lumborum muscle, and the anterior band is said to be part of the quadratus lumborum muscle. So over time, after the 3rd decade, it's said to become more of a ligamentous type of structure in nature, and then after the 6th decade, it actually tends to calcify. So it has blendings with the quadratus lumborum muscle, the ventral sacroiliac joint, and the thoracolumbar fascia. Keep in mind it has 5 bands. It has a vertical band, an inferior band, an anterior band, a superior band, and essentially a posterior band. Clinically, this ligament can become damaged, and it's not often that this ligament becomes damaged. Typically, the types of scenario where this ligament would be compromised would be with a motor vehicle accident, and usually it's a side impact motor vehicle accident where there's a lot of coronal type of forces that are translated to the spine, and in particular the lumbosacral junction. All right, to summarize the sacral ligaments, we have 2 that limit nutation, interosseous sacroiliac joint ligament and the sacrotuberous ligament, and 1 that limits counternutation, which is the long dorsal sacroiliac ligament. The thoracodorsal fascia, you can see here the extensive nature of the fascia. Its importance is in that of load transference. So from the trunk to the lower extremity, it transfers load. Many attachments to this fascia: transversus abdominis, internal obliques, glute max, glute med, erector spinae, latissimus dorsi, multifidus, and biceps femoris. They all have some blendings through fascial connections to the thoracolumbar fascia. And the other consideration is that it has different layers. It's got an anterior, a middle, and a posterior layer. And each of these layers blend in with various structures, various muscular structures. The pubic symphysis is the anterior portion of the pelvic girdle. It's a very fibrous joint. It's got fibrocartilaginous disc that holds it together. It has ligaments on the top and on the bottom, so the superior pubic ligament and the arcuate pubic ligament inferiorly. They blend in with the disc, so it makes it quite a stable joint, and essentially it is one of the components of the pelvis for stability. So when you compromise stability of the symphysis pubis, then the pelvic girdle as a whole is fairly compromised with its stability. So looking at this, one of the things that clinically is relevant is that the anterior and posterior portions of this joint, the ligaments, blend in with some of the abdominals and the adductor muscles. So we can influence this joint if there is instability here through strengthening the abdominal muscles and through strengthening the adductor girdle, the adductor longus in particular. Okay, and the final joint looking at the pelvic girdle is the sacrococcygeal joint. It's classified as a symphysis joint, but there have been reports that there's some synovial joints in nature. The ligaments are ventral and dorsal and lateral sacrococcygeal ligaments, and essentially this is a joint that can become damaged when somebody falls on their tailbone or has trauma to their tailbone. All right, so thinking about the muscles now around the pelvic girdle, there's 35 muscles that attach to the sacrum and the innominate, and basically it's these following groups. The obturator muscle group, the hip adductor muscle group, the tensor fasciae lata attaches to the pelvic girdle and sacrum, particularly the innominate, of course, the rectus femoris, the quadratus lumborum, abdominals, lat dorsi, and hamstring. So the significance of this clinically is that we can use muscle to affect the pelvis and affect treatment of the pelvis. And we see this with the use of muscle energy techniques when we're looking at affecting innominate motion or sacral motion or what have you. And we can also use muscle to improve the stability when it comes to treating the pelvic girdle if there is cases of instability. Particularly where you would find that would be with postpartum cases or peripartum cases, pregnant moms, or after they've delivered their babies. There's a higher chance of pelvic instability or hypermobility. Muscles that attach directly to the sacrum are the erector spinae muscle groups, the multifidus, gluteals, piriformis, perineals, the gemellis, and the iliacus muscle. Clinical relevance when we're looking at the stability for SI joint is multifidus, and in particular sacromultifidus. And there is a way that you can strengthen sacromultifidus to influence the sacroiliac joint that would improve the stability of SI joint. In particular, when you contract multifidus muscle, it enhances the nutation component of the sacrum, and that, of course, is the stable position for the sacroiliac joint. Okay, looking at some of the other muscles, transversus abdominis gets a lot of attention with core stability. This just shows you the anterior view, sort of a schematic, courtesy of Diane Lee, I believe, where it looks at the lower 6 costal cartilages and the thoracolumbar fascia that it blends in with. So it's got connections with that. It's got connections with the inguinal ligament, the anterior iliac crest, and it runs transversely to the linea alba and the pubis. It has connections also with multifidus muscle, the diaphragm, and it functions with these muscles actually, and the pelvic floor, and basically supports them and supports the pelvic girdle and the lumbopelvic area. So this is a sort of a very important muscle when we talk about core stability as well as pelvic stability. The other function, of course, is that it supports the pelvic and abdominal contents. When we look at it from a posterior lateral view, we can see the fascial connections. With contraction of the transversus abdominis, it acts to stiffen the spine through the thoracolumbar fascia. So because it connects with the thoracolumbar fascia, it helps to improve stiffness of the lumbar spine. And the significance with this muscle is that in a normal healthy state, it should activate in a feed-forward manner. And essentially what that means is that before you initiate any limb movement or loading limbs, this muscle should contract already. In cases where there's low back pain or dysfunction, oftentimes what happens is that you'll, let's say, move your limb and then the transversus abdominis will activate. And what that does is it increases shear forces to the spine and compromises the spine. When we look at excuse me. When we look at the sacroiliac joint for compression, pardon me. All right, so sorry, I had to have some water there. When we look at the sacroiliac joint, the transversus abdominis muscle actually helps to improve the stability of the SI joint, and it does this through compression. So because of its attachment into the pelvic girdle, contraction of the transversus acts like this girdle that essentially compresses the whole pelvis, and it can improve the compression component of the SI joint and therefore improve stability. Okay, multifidus is a muscle that most people are fairly familiar with. What I like is the picture on the slide, which shows the size of multifidus, the picture on the right, the primal picture there. And if you have a look at that picture, look at the size of multifidus in the sacral region. You can see actually how broad and developed it is when it comes to the sacral region, and it is clinically quite palpable in this region. And so when we look at retraining this muscle, we will palpate the sacral multifidus to see if it's equally contracting from left to right. Of course, it helps to maintain lumbar lordosis, and it does have a superficial and a deep component. The diaphragm, which forms another portion of the core, let's say, obviously is tonic in nature. It never turns off. It obviously turns on before limb movement as well, and it sort of acts as that feed-forward manner, just like the transversus did. But how it contributes to spinal control is through what's called pressurization and control of displacement of the abdominal contents. So it acts to sort of generate increased abdominal pressure or intra-abdominal pressure, and therefore improves the rigidity of the spine. So of course the diaphragm descends, increases sort of tension within the thoracolumbar fascia, and with the increase in intra-abdominal pressure, it improves sort of the rigidity of the spine. So that's how it helps to improve spinal rigidity. And oftentimes, when people go to lift something fairly heavy, one of the tendencies or natural tendencies is to sort of hold your breath. And by holding your breath, you're essentially improving that rigidity to the spine through the tension that gets generated with the thoracolumbar fascia and intra-abdominal pressure as well. All right, we need to just touch on the pelvic floor. The pelvic floor is comprised of the levator ani muscle group, which has puborectalis, pubococcygeus, iliococcygeus as well, and ischiococcygeus. So essentially it forms the floor of the pelvis. When we look at pubococcygeus and its connection from the posterior pubis and fascia of the obturator internus to the midline raphe, laterally it acts to compress the visceral canals and really doesn't have much influence on the sacroiliac joint. It actually activates with transversus abdominis to compress the symphysis pubis. So when you activate TAs, it will synergistically activate pubococcygeus and have an influence on symphysis pubis joint to compress it. Puborectalis posteriorly, it goes from the posterior symphysis uniting with the other side around the back of the rectum, and it blends with pubococcygeus. It's a muscle that tightens the external and anal sphincter to aid in voluntary retention of feces. So when you gotta go and you gotta hold it, this is the muscle that does that for you, puborectalis. One of the clinical factors is that it functions with rectus abdominis. So when you activate rectus abdominis, you're also activating a puborectalis muscle. The ilio and ischiococcygeius muscles run from the ischial spine, sacral spinous ligament, and fascia of the obturator internus to S3 in the coccyx. They run basically in the same plane as piriformis, and their job is to pull the coccyx forward following defecation. So essentially, the motion that they have on the sacrum is that of counternutation. And some research shows that they function with oblique abdominals. So meaning when you are contracting your abdominal obliques, you're also contracting ilio and ischiococcygeius. Now, if you think about it, if that's true, and if this muscle does act to cause sacral counternutation, then from an SI joint stability point of view, this is not favorable. We want sacral nutation when we want to be stable through the SI joint. So if you're performing core stabilization exercises with a client, then overactivation of your oblique abdominals may synergistically cause some activation of this muscle group, ilio and ischiococcygeius, and therefore promote counternutation of the sacrum, which is something that we don't want clinically. We want nutation of the sacrum. So something to be aware of when you're training core stability with clients to ensure that they're getting the deep abdominal muscles such as transversus rather than a lot of the oblique abdominal muscle activation. So what does the pelvic floor function to do? Essentially support the viscera and abdominal contents, assist with closure of the visceral openings. Contraction of the pelvic floor facilitates transversus abdominis activity. It acts as a force couple with multifidus to control the position of the sacrum. The ilio and ischiococcygeius muscle counternutate the sacrum, so we want to essentially avoid that. And one of the ways that we can avoid that is by having the client perform periurethral contraction versus perianal contraction. So what do I mean by that? Well, when you're training a client with core stabilization exercises and you ask them to perform pelvic floor contraction, you have to differentiate with what portion of the pelvic floor they're contracting. Is it the posterior aspect versus the anterior aspect? So if they're contracting the perianal region, then essentially that's going to promote more of a counternutation through the use of ilio and ischiococcygeius, rather than what they should be doing is promoting more of the anterior portion of the pelvic floor and contracting periurethrially. So this is that whole hold your pee concept, in terms of strengthening the pelvic floor, and that's going to achieve a better contraction of the pelvic floor muscle group, therefore facilitating transversus abdominis as well. And you can get this facilitated even further if you put them into a neutral or slight anterior tilt position of the pelvic girdle. All right, looking at the articular neurology, when we look at the nerve supply, what we're looking at is that there's both a direct and reflex influence on muscle tone, and this can happen locally and globally. Essentially, you have articular afferent input that contributes to perception of posture and motion. You have, essentially receptors within the joint capsule, and some of the ligaments are supplied by different divisions of the dorsal rami. Just be aware that L5, S1, S2, 3 spinal nerves contribute to this. The pubic symphysis is innervated by the pudendal nerve and the genital femoral nerves. All right, so looking at some joint mechanoreceptors that help to coordinate positioning, mobility, and stability, and improve biomechanical efficiency as well. So be aware that there's lots of mechanoreceptors that can help with stability. And then there's central effects that affect neurology around this region as well. So this picture just shows you the vast structure of nerve supply, both anteriorly and posteriorly. Innervation can be variable. Branches of the ventral rami L5, S3. There's lateral divisions of the dorsal rami of L5 to S3 on the posterior aspect. And there's basically what this slide essentially says is that there could be a variety of pain patterns with SI joint dysfunction because of the various branches that exist. Pain can be referred into the buttocks, the groin, the lower quadrant. And generally, though, one of the things that we tend to know through research is that pain doesn't generally fall below the knee. So pain above the knee can quite likely come from the SI joint region. If pain goes below the knee, then you've got to start thinking more lumbar spine as being the source of pain rather than sort of the pelvic girdle and SI joint region. Okay? The pelvic girdle muscles are supplied by spinal nerve roots of T12 down to S4, essentially. So quite the variance there. The blood supply. So the blood supply is primarily the median sacral artery. Supplies the sacrum, coccyx, and rectum. The other contribution for blood supply is the internal iliac artery, which gives off the lateral sacral artery that anastomosis with the median sacral artery. So there's blending of these arteries together. Essentially, they will supply the cauda equina and the sacrum, and later join in with the posterior gluteal arteries. So be aware of the blood supply. I mean, clinically, I don't concern myself too much with blood supply. When we're looking at musculoskeletal problems and when we're looking at mechanical-based pain, blood supply is not something to really look at too much into detail. But we certainly need to be aware of it and what arteries supply what structures. All right. So what I'd like to do now is move into the biomechanics section, and the next little bit is just going to touch on biomechanical movement of the pelvis and give you guys some insight on how the SI joints move. So they do move, and there was speculation at one point that the SI joints didn't move, and over time through research we've discovered that they do move. And when we look at movement of the SI joint, when we're looking at sort of flexion and extension in a sagittal plane, coupled with forward and backward bending, side flexion occurs obviously in the coronal plane with side bending, axial rotation in a transverse plane during twisting of the trunk, and there's obviously a combination of motions that occurs during gait. So one of the things that's been found through research is that there is rotation that occurs within the innominate. And this is said to be in the neighborhood of 2.5 degrees of rotation. And, I mean, when we're looking at translation within the joint, I mean, look at it. It's not very much, but we can perceive this motion occurring clinically. So 0.5 to 1.5 millimeters of translation is what's happening within the SI joint. So, again, not a lot. So clinically, when you're evaluating this joint, one of the key things is to not to overshoot your force or to push too hard, because you'll actually miss the movement. When we look at how the lumbopelvic region moves, flexion tends to be coupled with translation, PA translation, posterior to anterior translation, and it happens around a dynamic coronal axis with a little bit of anterior translation, about 1 to 3 millimeters. The inferior articular process of the superior vertebrae, L5, glides superiorly and anteriorly. So that means basically is when you look at L5 moving on S1, if you think of L5 moving into flexion, the motion that's going to happen at the facet joints on either side is going to be that L5 is going to glide superiorly and anteriorly on both facet joints with flexion. Obviously, with extension, it's the opposite. So when you look at extending L5 on S1, then L5 will glide in an inferior and posterior direction. So if you remember the picture of the facet plane at the lumbosacral junction, that's the motion that happens with extension. Side flexion is coupled with ipsilateral rotation and some translation as well. So if you look at the side flexion, the ipsilateral inferior articular process of the superior vertebrae, L5, will glide inferiorly and posteriorly. Okay, so let me repeat that and rephrase that. So what this is saying essentially is that if you look at L5, and let's assume that the person is going to side bend to the right. So you're standing behind them, you're observing lumbar spine motion, and you're watching them side bend to their right. So L5 vertebrae on the right side of the facet joint surfaces will glide inferiorly and posteriorly. With that same right side bending, on the left side facet joint surface, the L5 surface will move superiorly and anteriorly. Okay, so that's the side flexion coupling with rotation movement, and there's the translation that goes along with that. So looking at the osteokinematics of the SI joint, working through the innominate, the sacrum, and L5, and how they move relative to each other. This is something that you can actually do with a client or with another therapist when you're practicing, is work through the motion of how the innominates move relative to the sacrum and relative to L5. So what you essentially would do is you would look at trunk flexion, trunk extension, side flexion, and rotation, and you would also look at standing hip flexion. Now, when we look at trunk flexion, you could palpate the innominates, the PSIS in particular, and ask the person to bend forward, and as they're bending forward, essentially feel what's happening with the PSIS. You can feel that with trunk extension as well, and you can feel that with trunk side flexion and rotation. So I'm going to just work through this over the next couple of slides to see if we can sort of visualize what's happening. So with trunk flexion, if you are looking at the innominate, so imagine yourself standing behind the patient or the client, and you ask them to flex essentially their body forward. As they're flexing their body forward, the innominates come closer to the femurs. So they're said to flex relative to the femurs. Relative to the sacrum, so if you're looking at the innominate and comparing that movement to the sacrum, they are said to posteriorly rotate or stay posteriorly rotated as the trunk, the spinal column with the sacrum gets dragged forward into flexion. Okay, so think of L5 and everything above it, and S1 or the sacrum that's attached to L5. It's moving into trunk flexion. It's moving forward or anteriorly, and the innominates on both sides, on either side, are relatively remaining posterior. The sacrum remains nutated, though, throughout the motion. Okay, so that's important to remember, that the sacrum remains nutated relative to the innominates. So that means that the SI joint is staying stable. All right, L5 is said to flex and translate anteriorly on the sacrum, and this has been confirmed by research. We look at trunk extension. Trunk extension shows the opposite, that the innominates extend relative to the femurs. They posteriorly rotate relative to the sacrum still. Okay, so the reason that is because essentially the sacrum is staying in a position of nutation. So the innominates relative to the sacrum are still going to be posteriorly rotated, and we want that to be the case whether they're flexing or extending or side bending, because that maintains a position of nutation of the sacrum at the SI joint, and that's the position of stability. If there's any one thing that you remember from biomechanics of the SI joint, is that you want to keep the sacrum nutated. sacral nutation is important for stability of the SI joint, and that's what we strive to achieve clinically. All right, moving on, L5 extends and translates posteriorly on the sacrum. And again, this is confirmed by research. What we're not sure on is trunk side flexion, and it's more clinical observation than it is based on research. And so what we see clinically, and I certainly clinically have seen this quite a bit when I observe, side flexion and I look at SI joint movement. If you imagine yourself basically looking at the right side, let's say, of the person, and you're standing behind them, and you're looking at innominate motion. Now, if you were to palpate the PSIS with either thumb, so your right thumb on the right PSIS, your left thumb on the left PSIS, and the rest of your hand is basically grabbing on to the rest of the ilium. You ask your client to side bend to the right, and as they side bend to the right, what I have observed clinically, and many other therapists I know have observed clinically, is that the innominate on the right side will move towards anterior rotation. The innominate on the left side will move towards posterior rotation. Okay, so with right side flexion of the trunk, the right innominate rotates anteriorly, the left innominate rotates posteriorly. Now this is ever so slight, but you should be able to see a difference between the two sides. The sacral base is said to rotate towards the left. Okay, so the right sacral base essentially stays nutated. Okay, so if you think of it as the sacral base, looking at the sacrum, it tends to sort of bias a rotation to the left. And if you think about it, if they're side bending to the right, they're putting more load to the right side of their body. And as they're putting more load to the right side of their body, you're going to get more force going through the right portion of the SI joint, okay, so or the right SI joint. So that has to stay more stable in order to support that. So it will nutate a little bit further than the left SI joint, and that gives rise to some of that rotation within the sacrum. L5, we're not sure. It's said that it side flexes to the right and it rotates to the same side, or it can rotate to the opposite. That we're not completely sure on, so we need to feel that clinically. Now, rotation, trunk rotation, again, is clinically something that we're not sure on and can agree on, but essentially I have seen clinical patterns like this, and many therapists that I've talked to have also seen this same clinical pattern. So it hasn't been confirmed by research, but this is what we see clinically. Again, if you have your thumbs on the PSIS and your hands on the ilium, and you ask your client to rotate their trunk to the right, then the innominate on the right will rotate posteriorly, and the innominate on the left will bias rotation anteriorly. The sacrum follows the spine with that right rotation, and it will rotate slightly to the right as well. It sort of gets dragged along with L5 and rotates to the right. So L5 is said to rotate to the right, but again, there may be a conjunct movement that occurs with right rotation, and we're not sure what that is. All right, so if you ask your client to do a standing hip flexion test, so they're standing, they bring their knee up to their chest, this is typically what you would see happening with innominate motion and sacrum and L5 motion. Again, palpating PSIS on the right and looking at the sacrum relative to that. This is also known as a kinetic test. The right innominate is said to move posteriorly relative to the sacrum. The right PSIS, think of it as the right PSIS moving down, and the femur flexes relative to the innominate. So they bend their knee up, you're looking at the PSIS moves down relative to the sacrum, and that would be a standing hip flexion test. Sacrum is said to rotate to the right, but again remains nutated. And L5 is said to rotate to the right as well a little bit. All right, looking at the innominate rotation, so you can see anterior innominate rotation and posterior innominate rotation. So looking at this slide, and if you look at the left part of this slide, that goes with anterior innominate rotation. What we're looking at is, again, that SI joint surface. And this is that L pattern, again, of the SI joint surface. If you look at the L, you can see that essentially there's an L that's lying on its back, right? The long portion of the long arm of the L is lying on its back, or as horizontal, and the short arm of the L is actually vertical. So this signifies the movement that's happening within the SI joint. With anterior innominate rotation, what happens is that you get a glide along the short arm in an inferior direction and a glide in the long arm in a posterior direction. So essentially, with anterior innominate rotation, you have an inferior-posterior glide. Inferior on the short arm, posterior on the long arm, and this happens together. If you were to reverse that motion and go posterior innominate rotation, you get the reverse glide occurring. You'll have an anterior glide along the long arm and a superior glide along the short arm. Combine the two together and you get an anterior superior glide with posterior innominate rotation. Okay? So something clinically to remember, because when we look at evaluating the SI joint in terms of passive mobility, we look to feel for this rotation and this essentially this gliding effect. So anterior innominate rotation glides inferior down the short arm and posterior along the long arm. Tight rectus femoris, tensor fascia lata, iliopsoas muscle groups, these can all promote anterior innominate rotated position. Weak glutes, hamstrings, and abdominals also promote that. Posterior innominate rotation glides superiorly up the short arm and anteriorly along the long arm. And again, what can influence this is tight gluteals, hamstrings, rectus abdominis, weak rectus femoris, essentially tensor fascia lata, and iliopsoas. Okay? Now the sacrum also moves, and so we know that it moves into nutation, which is the position of stability, facilitating what we call form closure, where the bones just sort of connect together, increases SI joint compression, and efficient load transfer. It's resisted by interosseous and sacrotuberous ligaments. It's wedge-shaped in nature, so that improves the stability of the sacrum as well. It has ridges and depressions in the articular surface, which improves the friction coefficient, and again, promoting stability. Forward motion of the sacral promontory into the pelvis about a coronal axis is what we consider to be sacral nutation, okay, within the interosseous ligament. The sacrum glides inferiorly down the short arm and posteriorly along the long arm. So if you look at motion of the sacrum moving on the innominate, then if you look at sacral nutation, it's going to glide inferiorly down the short arm and posteriorly along the long arm. What I described previously was movement of the ilium on the sacrum. Counternutation is a position of instability as a result of weak multifidus, strong ischiococcygeus muscles, or loss of form closure. Essentially, counternutation is an unlocked position of the SI joint. It disengages the self-bracing mechanism, and it can lead to failed load transference. This is where pain can start to kick in or start to set up an SI joint dysfunction. It's resisted by the long dorsal ligament and multifidus, so we want to think about those two structures in rehab. Backward motion of the sacral promontory away from the pelvis about a coronal axis is what we consider to be sacral counternutation. So if you look at sacral counternutation now, looking at the sacrum moving on the ilium, it will glide anteriorly along the long arm and superiorly up the short arm. That's sacral counternutation, superiorly along the short arm and anteriorly along the long arm. And this gives you a visual of now the sacrum moving into nutation, first picture on the left. So again, inferior posterior glide versus sacral counternutation, picture on the right, looking at anterior superior glide at the SI joint surface.